Okay. Shall I start?
Okay,
Hello.
ma'am.
Shall I start? Hello.
Sure, ma'am. Sure, ma'am.
Please speak little more loudly, no?
Sure, ma'am. Please start.
Okay. Good evening, everybody. We shall be talking something about diuretics, their rationality in their indications mainly, and also in adverse effects, so that we have to take care of the patient in a very nice way, because our body is made up of fluids and electrolytes basically. And for survival also, we need water and mainly sodium, potassium and chloride. Apart from that, we do need calcium and magnesium, but these are the three primary ingredients along with water, what is needed by the body to take care of day-to-day activities and also in every cell. So, whenever there is an alteration, and the main alteration takes place whenever there is a renal overload or renal dysfunction. So, keeping this in mind, we will talk something about these diuretics, where to use, where not to use, or can we use right from an MBBS person to a consultant, or is it restricted to certain parts of the of a practice only? But in today's era, because of the non-communicable diseases, we can use right from MBBS itself, and most of the times, even if we don't want to use, they come for refilling of prescriptions and also the adverse effects faced by these drugs, so that you should know where to continue, where to decrease the dose, and how to correct the adverse effects. So with this background, we will just talk a few things, and then we will go to some quiz type questions, so that I think you people can answer. With that, we will come to some of the other rationalities also. So as all of you know, diuretics increase the sodium and water excretion. Not only the water excretion, but also sodium. So it is natriuresis. It is natriuresis, where it decreases the ECF and effective circulatory volume. It should be only 5 liters of blood at any given time. Whenever this is increased, it will see to it that it comes back to near normal of 5 liters. So diuretics interfering with normal sodium handled by the kidney. So how are they handled? The main theme is the target molecules are specific renal tubular membrane transport proteins in whichever part of the nephron they are. So this is the basic one, what is needed. So you have to target it for the renal tubular membrane transport proteins, where they have to get secreted on the luminal side and then start acting. So the process should be in such a way that the drug should get absorbed properly, then it should get combined with albumin and then come to the renals, and then it should come to the luminal part, and only then it acts, except spironolactone as well as eplerenone, where they bind to the receptors, whereas all the others will act on the luminal side of the membrane. So we have to see that adequate quantities of the diuretic drug must be delivered to its sites of action. So our pharmacokinetics, normal pharmacokinetics, should be absolutely fantastic, especially absorption, distribution, and that distribution taking the molecule to the renal tubular membrane on the luminal side. So normally, what is the normal physiology? A glimpse, that's all. I'm not going to total physiology. It's only a glimpse, where as all of you know, they are divided into different, nephron is divided into several segments. In the proximal convoluted tubule, major sodium is absorbed. And the transporter is sodium hydrogen, and also angiotensin 2, which is a very powerful vasoconstrictor. Next, in loop of Henle, 20 to 30% is reabsorbed, but the important mechanism is sodium, potassium, 2-chloride. All the three are reabsorbed back. And in distal convoluted tubule, only 5 to 10% with sodium chloride importer, chloride being the main ion, only 5 to 10% of sodium is absorbed. But when there is locking in loop of Henle and proximal convoluted tubule, distal tubule takes a major share in the reabsorption of both water as well as sodium. The cortical collecting segment is 1 to 3%, where there is epithelial sodium channels and also aldosterone, and two types, ENAC direct channels, as well as the hormones, that is aldosterone, In between that, we have PTH, aquatics, as well as calcium. So all of them are there in the collecting ducts, which will really show us how important is the collecting duct amongst the whole of the nephron. Lastly, medullary collecting duct, where we see that epithelial NA cells, that is ENAC, and atrial natriuretic peptide is the one which mainly concerns in these areas. So this you remember, because we have to know how much of sodium is reabsorbed and how much of sodium is thrown out to say that whether they are suffering from only dilutional hyponatremia or real hyponatremia, which may be the main side effect of many of these diuretics apart from the major hypokalemic mechanisms. So these are the glimpse of drugs what we have in the proximal convoluted tubule. Most of the drugs are filtered by glomerular GFR, that is glomerular filtration, apart from albumin bound drugs. So the majority of the diuretics are albumin bound, so they have to come to the luminal side after getting redistributed, and from the tubular side they have to come to the luminal side, except aldosterone and the potassium sparing diuretics, that is trimetrin and amiloride. So in proximal convoluted tubule, the main medications are carbonic anhydrase inhibitors, which are very weak diuretics. Okay, but major they are, because they increase osmolality and just bring down the concentration of the fluid from the higher concentration to the lower concentration. We mainly use it in glaucoma, and also they increase the oxygen capacity. So we use it mainly in acute mountain sickness, where we have other uses but not very much used clinically. The part of osmotic diuretics or osmotic diuretics are also do have an action in proximal convoluted tubule, but the main action is throughout nephrons, and it is rarely used as a particular diuretic in PCT. The next one is in the ascending loop of Henle loop diuretics, which has got the strongest diuretic action, hence named as high ceiling diuretics or high efficiency diuretics. And in descending loop of Henle, as osmotic diuretics as throughout the nephron, you can quote even in this position the osmotic diuretics also. The next one is thiazides, which are weak diuretics which act on distal convoluted tubule mainly through chloride mediated mechanism. And lastly, the collecting tubule and the duct, where the main site of action is aldosterone receptor. So antagonists are used where we have very weak to moderate diuretic action. They're all, most often, they're all add-on drugs due to some other actions and mechanisms and advantages. Then next is direct acting channels, that is epithelial sodium channels antagonists, where again they have the weakest diuretic action. They are mostly used in non-edematous conditions. And lastly, vasopressin 2 receptor agonists, where they are known as aquaretics. Aquaretics, and only water is excreted, sodium is preserved. Unlike other diuretics, where we have natriuresis, where we have only aquaphoresis. I hope you can make out the difference. Now, coming to little bit of specific, major, important, which should be remembered, actions of each one of them, what I tell you. Only the important ones I'm telling you. I'm not going to tell you the usual ones, which you people might have really been through and through, and you may know better than me. So the main ones which are used and effects clinically, only those things I'll be speaking here. The first amongst the lot is furosemide. Furosemide basically has three main actions. Okay, three main actions. Whenever given orally, IM, IV, it has got all routes of administration. Whenever we give by non-IV route, the two main actions are it blocks sodium potassium 2 chloride importer, okay, thereby increasing the excretion of sodium and chloride. Also, there is renal vasodilatation because of prostaglandin mechanism. These two are the most important things what you have to remember. Why? Blockade of sodium potassium 2 chloride importer blocks all the electrolytes, so that there is total electrolyte imbalance. Apart from this, this affects the paracellular pathway, where there is excretion of calcium and magnesium also. So hence there is total electrolyte imbalance. Second, the renal vasodilatation occurs because of prostaglandin mediated, and this prostaglandin Normal physiology is prostaglandin mediated vasodilatation. And we people do take OTC, that is NSAIDs, without knowing to anybody. Any time Dick and Harry are known to take NSAIDs because they are over-the-counter drugs, which will block this vasodilatation and hence decreases the renal blood flow and hence might cause edema on a long scale. And we will be wondering why this edema is, but again, the drug is a problem. So drug history is a very important entity in today's world so that we can know what are the drugs which are interfering with our physiological system because of over-the-counter drugs and the Google. So because of this, first you have to take the drug history, then the patient complaints, then the present history, then the past history, then the family history. So you please make a turn nowadays because anybody and everybody are known to take some or the other drugs before coming to the doctor. So these two are the major mechanisms and hence you have got a plethora of actions of furosemide. So first is block sodium potassium 2 chloride importer, excretion of sodium and chloride. Okay, then there is decreased carbonic anhydrase activity, then renal vasodilatation, then we have sodium potassium exchanger, so potassium loss, then increased calcium excretion by paracellular pathway, so hypocalcemia. So this portion, the whole of these portions will constitute for electrolyte imbalance, the whole of this down portion. This portion constitute for edema, drug-induced edema, and a drug interaction between loop diuretics and NSAIDs. And here it is mainly metabolic acidosis because of decrease in carbonic anhydrase activity. And when given IV, this is a common example what I quote in every class of mine or every talk of mine. Whenever furosemide is given IV, to tell you the best example, the patient who cannot even say his name completely, okay, who cannot even say his name completely, just after giving IV, just the moment you finish the last drop of furosemide, he is able to tell his name completely. That is the case in pulmonary edema. So what happens in pulmonary edema? When furosemide is given IV, because of venodilatation, the fluid shifts from the pulmonary circulation to the systemic circulation and hence the pulmonaries are only with air and there is decreased filling pressure also and hence pulmonary edema is relieved. This action occurs much before the diuretic action. This should be remembered for lifetime whenever you are using furosemide. So these are the three important mechanisms how it is used in plethora of conditions where especially in cardiovascular diseases, edematous conditions and also in certain of the non-edematous conditions also. So now coming to the clinical status and rationality of each one of them. I am focusing more on loop diuretics and comparing with other things. Okay. So I hope you people are understanding. In acute LVF or acute pulmonary edema, the dose of furosemide is about 40 to 80. We can start from 20, but of no use in acute left ventricular failure and pulmonary edema. Here it shifts from the fluid shifts from pulmonary circulation to the systemic circulation before the onset of the diuretic effect and hence edema is relieved. So sometimes if the patient is already on furosemide, we choose bumetanide. But most often in every cases, we see that we try to increase the dose of furosemide and we use furosemide more than every other loop diuretics because of its high efficacy and efficiency. Okay, apart from furosemide, which other drugs can reduce acute pulmonary edema? Morphine. Morphine also can reduce pulmonary edema because of decrease in preload and afterload. Decrease in preload and afterload, that too immediately when given IV. So these two are the major drugs which can be used in acute pulmonary edema. Because of euphoria and other things, and also the availability, furosemide is the drug of choice in pulmonary edema. In CCF again, if the patient is almost going to pulmonary edema, or if the volume overload is too much and we have already put the patient on anti-mortality drugs, that is AC inhibitors or ARBs, beta blockers, that is most often carvedilol. The second choice is metoprolol. Okay, then MRAs, spironolactone or eprednone. Eprednone is better. Then we come to CCF, and that too we restrict it to 20 to 60 mg, unlike in edema where the dose is much higher. And here we use it because of the additional actions what we get, and volume overload is completely decreased and renal blood flow is increased. Both actions will take place, and for that reason we use only in acute CCF when the patient is dyspneic and other things. Otherwise we shift on to our usual thiazide diuretics, and also nowadays thiazide like diuretics, that is chlorthalidone, or in resistant cases metazolone. In case of metazolone, we have found that mortality is more compared to furosemide and thiazides. So still we are restricting it. We're restricting thiazides with combining along with AC inhibitors or ARBs, or we can have a sequential blockade with furosemide as well as thiazides and also spironolactone, thereby not only having sequential blockade but also combating the adverse effects where hypokalemia is caused by furosemide as well as thiazides, and hyperkalemia by spironolactone. So each one is combating the adverse effects of each other, and so normal potassium level is maintained. We are more worried about potassium amongst all electrolytes because this is the one. Hyperkalemia is also a problem and hypokalemia is also a problem, which mainly affects the heart. And so we have to be very vigilant regarding this. And so we use these two drugs, and so we should be more bothered about potassium. Next, as I told you, we use potassium sparing diuretics mainly with thiazides or furosemide or with AC inhibitors, and this spironolactone not only combats for potassium balance but also increases the survival benefit, especially in CCF. It has got an anti-fibrotic activity. Once this anti-fibrotic activity is enhanced, the remodeling activity is decreased, and also the apoptosis is decreased indirectly. So we always choose the third anti-mortality drug as mineralocorticoid receptor antagonist. The third edematous condition where there is salt and overload are the nephrotic syndrome. Is this nephrotic syndrome where we use a very high dose, 100 to 200 milligrams, because of hypotension, because the urine blood flow is almost less than 20 ml per hour. Oliguria is there going on to anuria also. So we give every 6th hourly IM and IV. Furosemide is the drug of choice. We can use it along with the other electrolytes, but initially we have to use it at a higher dose to combat all the effects of nephrotic syndrome, whatever we see. A great loss compared to CCF or acute pulmonary edema, we see a great problem in nephrotic syndrome. So we have to lessen and increase the renal blood flow as well as glomerular filtration rate, and also decrease the edema. For that reason, we are using this in a very high scale. Next, in case of cirrhosis, in case of cirrhosis, these two will act as adjuvant. The main one will be spironolactone. The main one will be spironolactone. The main will be spironolactone, because here we see that there is increased aldosterone secretion in any case of ascites, or cirrhosis. In both these cases, we see increased aldosterone secretion. And so we want to see that the aldosterone, hyperaldosteronism is decreased. And so spironolactone is the first drug of choice. But we can add it with furosemide or sometimes, very rarely, with thiazides, because thiazides and mannitol are contraindicated in cirrhosis of liver. We commonly use aldosterone with furosemide to combat their side effects. The next one, these are all some of the non-edematous conditions where we have hypertension. Furosemide we are using. Can I see that this is removed, the upper one? Yeah, thank you. Hypertension. In hypertensive emergencies, as all of us know, the first drug of choice is labetalol nowadays, then sodium nitroprusside, then enalaprilate, then nicardipine, then all these are the drugs which we use nowadays. But when we also use in certain of PHCs and other centers where we don't get these drugs, we use furosemide also in hypertensive emergencies as one of the drugs of choice. And these are used in resistant hypertension also when 3 or more drugs are already given. And when we call it as resistant hypertension, we call it when more than 3 drugs, including a diuretic, is used. In such cases, furosemide can be used additionally to decrease the blood pressure, which is not coming down in spite of 3 or 4 drugs. And in any case of renal dysfunction, furosemide is the drug of choice. And along with AC inhibitors and ARBs, we use these thiazides as first drug of choice in mild to moderate hypertension, and to decrease to combat hypokalemia, we use these potassium sparing diuretics in case of resistant hypertension. In acute renal failure or acute injury, it increases the urine flow, and increased excretion of potassium also takes place and converts the oliguric phase of acute renal failure to non-oliguric phase. These are the things what to be noted when we give it in acute renal failure. First, the diuresis will take place. Okay, because there should be increased glomerular filtration rate and increased urine outflow because of acute kidney injury. We have to make the kidney work. So there should be increased rate of urine flow. Along with that, we should see to it that the oliguric phase is converted into non-oliguric phase in these cases. Chronic renal failure, we normally use it to reduce only the edema because that will increase the volume overload. So we have to reduce the edema, and hence we are using it in chronic renal failure. And severe resistant edema, we are using along with thiazides or with spironolactone as explained before. Next, in cerebral edema, here it is not a diuretic, but it will increase the osmolality. Mannitol does not cross the blood-brain barrier. Mannitol, please remember, mannitol does not cross the blood-brain barrier. It acts throughout and it decreases. It acts on all parts of the nephron, and it also it increases the plasma osmolality. It increases the plasma osmolality, and it is free filtered non-metabolized sugar, and it will cause osmotic diuresis. So here, what is the basis of the osmotic diuresis? It raises the serum osmolality since it does not cross blood-brain barrier, causes a positive blood cerebrospinal fluid osmotic gradient, resulting in brain dehydration without affecting the brain blood flow. Okay, and hence increasing the intracranial pressure. Also, it is not reabsorbed, and it causes a washout on the medullary solute gradient, inhibiting the countercurrent urinary excretion of the function, so that it draws water throughout the nephron and hence exerts this osmotic effect. And also it can be simulated even to glucose, though glucose is not called as a diuretic as such. So the action of mannitol in cerebral edema, though it is an edematous condition, it does not cause diuresis. Instead, it causes brain dehydration, and also the fluid comes out from the higher concentration to the lower concentration, and hence decreases the intracranial pressure. Next, in cases of hyperkalemia, We use furosemide, as I told you, because it causes hypokalemia, and we should use it along with sodium chloride and water. Otherwise, furosemide normally causes natriuresis. There is loss of water, dehydration, hypovolemia, and sodium imbalance, that is hypokalemia. So to combat that, we use furosemide with sodium chloride and water, or with normal saline, to combat this hyperkalemia. The same thing holds good with hypercalcemia, but here it is isotonic saline. It is not with water, it is with isotonic saline we use in case of hypercalcemia. How does hypocalcemia occur? Because the sodium potassium 2 chloride, when it is blocked, it also blocked the cellular pathway, thereby causing depletion of calcium and magnesium also. Now, coming to the other uses, apart from edematous and other cardiovascular use, we use in certain other conditions also, mainly in poisonings. In poisonings, we have especially barbiturate, but we do not have so much nowadays barbiturate and aspirin, because they are almost outdated nowadays, because we have got better drugs in epilepsy, and also NSAIDs, we have got a better ones, especially COX inhibitors. So we rarely use aspirin. Is mainly used as low dose aspirin in all cardiovascular conditions or cardiovascular accidents. So it's quite rare, but for your exams, to remember, to be in PHCs, or to have a own clinic, in all such cases, you might find these things, because the pharmacy people do give it on their own, these drugs, and patient, because of OTC, they might come back with these problems. So here we use FAD with alkaline diuresis. What is FAD? FAD is forced alkaline diuresis. What do you mean by forced? Forced is through diuresis, either furosemide or mannitol. Alkaline is you are making the urine alkaline by giving sodium bicarbonate, and hence diuresis, increased flow of urine takes place, because any drug which is lipid insoluble and which is ionic will get excreted by the kidneys without reabsorption at any part of the nephron. So we have, whenever there is no specific antidote, we use this post alkaline diuresis before going on to hemodialysis. Post alkaline diuresis, which is wonderful, but we have to sit with the patient for at least 24 hours to get a beautiful effect. Even today, this will be more than sufficient. All fancy things, we go to hemodialysis because we don't have patience, but this is the most wonderful treatment what we have whenever we don't have antidotes for any of the acidic poisons. And furosemide is also drug of choice for any of the iodide-like compounds. In such cases also, we use furosemide. In case of life-threatening hypernatremia, in case of the life-threatening hypernatremia, we use furosemide with hypertonic saline 20 to 80 milligrams, so that sodium concentration becomes normal. The other common use is glaucoma, where we use acetozolamide, where the carbonic anhydrase enzyme, which is H2 plus CO3 is H2CO3 in presence of carbonic anhydrase, where this is inhibited. So H2CO3 is inhibited, which is a main component in aqueous humor. So when this increases to a very great extent, there is pressure on the back structures of the eye, and hence there may be blindness. So to reduce the pressure and bring back to normal, especially in acute congestive glaucoma, acetazolamide 500 mg IV or oral, along with mannitol IV drip, and along with topical ones like brinzolamide, latanoprost, pilocarpine, and timolol are used before going on to laser iridectomy. But nowadays, in chronic cases, we use topical carbonic anhydrase inhibitors like dorzolamide, brinzolamide, okay, which has got an additional actions where they increase the uveo-sacral outflow also, and hence prolongs the deterioration of glaucoma at least by a decade. The next in glaucoma also, we use mannitol, especially in acute congestive. In chronic simple glaucoma, we use topical carbonic anhydrase inhibitors. Acetazolamide has one beautiful indication, that is acute mountain sickness. Here, because of increase in oxygen content at that high altitude, there is, first of all, there is increased carbon dioxide at high altitude, where this will counteract completely, and hence see to it that the oxygen content is increased. Oxygen content is increased, and so we see to it that there is an additive effect, and so we see to it at high altitude is a low oxygen content, and the action of acetazolamide decreases the incidence of tissue hypoxia. Tissue hypoxia, how does it do it? Because acetazolamide is a carbonic anhydrase inhibitor. In the proximal convoluted tubule, there is loss of bicarbonate, okay, leading on to metabolic acidosis. And this physiological response is compensated for the loss of bicarbonate ions by decreasing the level of carbon dioxide in the or by causing respiratory alkalosis. So this takes this when there is respiratory alkalosis, there is hyperventilation, which leads to increased expiration of carbon dioxide, leading to high partial pressures of oxygen in the arterial blood. And as high altitude is a low oxygen environment, the action of acetazolamide decreases the incidence of tissue hypoxia in high altitude, and thus it is a drug of choice in acute mountain sickness or altitude sickness. Now, coming to other general uses, a glimpse. Okay, diabetic insipidus, which can be of central or nephrogenic in origin. In nephrogenic, mainly due to reduced response of vasopressin. We do have drug-induced also. We'll come to it later. Thiazides are the drugs of choice where they act paradoxically. There is no real good action, but they act paradoxically. Actually, they excrete water, but here in this case, they reabsorb both sodium and water in the collecting duct, and hence they are useful in diabetic insipidus. So the word paradoxical is of much important than the real actions of thiazides. In case of lithium-induced nephrogenic diabetic insipidus, instead of thiazides, we normally use amiloride, which blocks the lithium transport to amiloride to lithium transport in the collecting drugs, and hence it will decrease the toxicity caused by lithium. The next one is idiopathic hypercalciuria. When we come to adverse effects, we see that furosemide and thiazides have got the same adverse effects except hypercalciuria. Except hypercalciuria with thiazides, whereas hypocalciuria with hypocalcemia with furosemide and hypercalcemia with thiazides. So whenever there is idiopathic hypercalciuria, we use thiazides and hence see that the excretion is enhanced. And in hypertension, we always use thiazides at lower doses, 12.5 to 25 milligrams, along with AC inhibitors or ARBs or even other drugs. Why do we do so? We use it for two main reasons. One is initially decreases the blood volume, but that has got tolerance or resistance. And next, because of vasodilatory activity, blocking the calcium directly in the blood vessels, it causes vasodilatory activity. And so this is the first drug of choice in elderly hypertensive, especially above 80 years. In case where there is resistance, okay, where there is resistance, in such cases, we use this subtherapeutic dose of indapamide, which will inhibit the calcium in the vascular smooth muscle, and also it has got a longer duration of action. Because of these two reasons, in hypertension not working for usual drugs, we do add this indapamide. In case of impaired renal function, where GFR is less than 20 ml per minute after all the other drugs, and in cases of diuretic resistance, we use another drug known as metazolone. So this drug is commonly indicated in resistant CCF and impaired renal function. As this spironolactone can be used in hirsutism as well as PCOS because of its anti-androgenic effect. And in cases of low renin cases, there is increased volume and hypertension, which we call it as Little syndrome. Here, tamtarine and amiloride are used because they block the ENAC in the collecting duct, and hence the activity of renin is decreased, RAS is decreased, and hence we see this problem comes to a standstill when we use these drugs as a sole agent where we never use in other conditions. In case of metabolic acidosis, diuretic-induced alkalosis, hyperphosphatemia, and familial periodic paralysis, we commonly use acetazolamide. And in dialysis disequilibrium syndrome, dialysis disequilibrium syndrome, where most of the patient will be very tired after a dialysis because of hypotension, we commonly use mannitol, which increases osmolality. Because of that, the oncotic pressure is increased, and so the volume is increased, and it facilitates the fluid from ICF, to ECF, and facilitates the action of potassium binding resins also in case of dialysis. So because of these reasons, we try to use mannitol in these cases. Now, coming to a few words about ADR, I've divided into 4 actions so that you can make out, even along with this, when we use other drugs also, you can be rest assured these are the problems which are met, and so be careful when we are using these drugs. So start with a low dose, and whenever you are going for a high dose in acute cases, monitor for electrolyte imbalance and renal function test to be safe on the safer side as well as more. So the common electrolyte imbalance, all 5, sodium, potassium, chloride, magnesium, calcium, all 5 are with loop diuretics. Okay, so total electrolyte imbalance along with water excretion takes place in loop diuretics. Okay, then with thiazides, all others are hypo except calcium hypercalcemia. And in spironolactone, it is hyperkalemia. So you have to see which combination will be better, or when we use all these 3, a phenomenon known as sequential blockade is brought about. The other examples of sequential blockade in pharmacology is an antibiotic, that is co-trimoxazole, trimethoprim with sulfamethoxazole, or amphotericin B with flucytosine antifungals, okay? Or even sometimes we have these are the 3 main components where we have as sequential blockades in pharmacology. Sometimes we do have some of the other drugs also, like penicillins as well as aminoglycosides, but not to that extent. We have got additional effects, but the typical sequential blockades are these things. The allergic reactions are mainly because of sulfonamide moiety, what we see with loop diuretics and thiazides, structural abnormality. So any drug which has got the sulfonamide structure, example, clofazimine, dapsone, so sulfonyl ureas, sulfonamides, all these belong to the same group. So whenever we are using, the allergic component might be more compared to the other things. So you have to be very careful, and most often they might produce even Stevens-Johnson syndrome. So we have to be careful with allergic reactions. Next, metabolic disturbances, mainly 3. One is hyperglycemia, hyperuricemia, and alteration in lipids. These are the 3 main metabolic disturbances was what we see. The metabolic disturbances are same with furosemide and thiazide. Both of them cause hyperglycemia and hyperuricemia. So whenever we want to use these drugs, we have to take the history of gout and diabetes. So look into the actions, and so we have to use different sets of diabetic drugs whenever furosemide and thiazides are absolutely indicated. The metabolic disturbances with spironolactone is mainly estrogen side effects, anti-androgenic effects with spironolactone, more than the 3 what I told you. Organ toxicities are very common with furosemide, which are quite reversible, and it is a dose-limited toxicity. So if the nephrotoxicity is compacted, ototoxicity reverses on its own. But be careful whenever we use furosemide with aminoglycosides, furosemide with vancomycin. So these are the problems which are met, and so these are the very common drugs what we use day in and day out. So you have to be careful whenever we use drugs which causes ototoxicity and nephrotoxicity. And most of the times nowadays, after this stewardship and other things, we are using very commonly furosemide, gentamicin or tobramycin, and vancomycin, especially for this MRSA and other things. So be very careful whenever we use these drugs, and especially in case of myasthenia gravis, do not use these drugs because they may cause neuromuscular blockade also in addition by various mechanisms. Now, coming to a small note on drug interactions, which is very, very important, which we see day in and day out. Though we have not administered the drug, the patient would have got administered elsewhere, and they come with drug interaction more than anything else. So you have to be, even if you don't know the use and adverse effect, know the drug interaction, see the discharge summary, see the drug history there, and see that what is causing the problem with the patient. Because when you give furosemide, all diuretics most often are given only in the morning. If the additional dose is required, we have to give maximum by 3 o'clock because when given afterwards, it will disturb the sleep. And also nocturia will be there. So because of that, we restrict it, and most often we give it at 6 o'clock in the morning so that they will have a very good, quick effect, especially with loop diuretics. Okay, so only one dose should be given. And why? Because of these reasons. And when most often we are using a combination of drugs because today is the era of polypharmacy and many of them are encountering all non-communicable diseases like cardiovascular conditions, diabetes, hypertension, hyperlipidemia, bronchial asthma. So these are the problems. So hypotension, electrolyte imbalance, all these are the common issues what we see. And I had a patient who went on to CCF, but he was put on exclusive furosemide, not counseling them regarding diet or other things. So he used to take 40 mg twice daily and he could not even lift his calf muscle. So where is the question of walking? He could not even lift the calf muscle. So these are the problems, patient-oriented problems, which we see day in and day out. So be careful whenever we are adding these drugs. The drugs which have synergistic effect are thiazides with loop diuretics, a sequential blockade effect. So it enhances the diuresis and also the adverse effects also. The second common one is increased activity with oral anticoagulants, furosemide, and decreased activity with thiazide, mainly increased activity with oral anticoagulants. So when there is increased activity of oral coagulants, you have to monitor INR, you have to see whether the patient is taking drug properly, decrease the dose of the drug, decrease the drug interaction with warfarin, both with increased protein plasma protein binding, decreased plasma protein binding, etc. All pharmacokinetic and pharmacodynamic interactions with warfarin. Now thiazides with digoxin will increase digoxin toxicity. So you have to be very careful, and so you have to know whether really to administer or not. So also lithium at the renal level, digoxin with thiazides at the cardiac level, lithium and vitamin D at the collecting duct level, where it cannot exchange lithium with thiazides, and so it can cause toxicity and enhance the toxicities when we add these drugs. ACE with potassium sparing diuretics, both of them put together causes hyperkalemia, a synergistic effect, so the patient can land up in any of the cardiac abnormalities. Lastly, pentamidine and trimethoprim increases hyperkalemia, and so you have to be careful. Along with that, they have got sulfonamide activity also, so allergic reactions are also very common. The antagonistic activity, we have seen right from second year, I think we have learned probenecid with NSAIDs and with furosemide, NSAIDs with furosemide, probenecid with furosemide, and NSAIDs with furosemide. These two actions are at the level of the kidneys. This is at the PG vasodilatation. PG vasodilatation or NSAIDs with AC inhibitors. All these are because of PG vasodilatation, where the PG vasodilatation is not there, which is a good effect physiologically also, which is blocked totally and results in edema, where we will be finding out umpty number of investigation to find out what is edema. Just a simple questioning of drug history will solve everything. The one which has to be solved with 5 paise, we take it to 50,000. So this is the era of treating from the doctor's side. So also from the patient side, because of Google, these are the problems. So be very careful. Ask about drug history, drug history, drug history today, because everybody comes with a drug to you. Without a drug, we cannot see anybody at all, right from a uneducated person to a total educated person. They will come with one or other drug, then they will ask for refilling or for a consultation. Then you have to know about these drug interactions. And again, with thiazides and spironolactone, they can antagonize their the effects and cause edema. Then decreased activity with thiazides, especially oral anticoagulants. Then there will be thrombosis, so you have to be very careful. The organ enhancing toxicities, ototoxicity with aminoglycosides, then minocycline, a congener of tetracycline, vancomycin, which has to be given only IV. The only indication for oral route of administration is pseudomembranous colitis, but alternatively, we have got metronidazole nowadays. Salicylates, precipitate, and loop diuretics increase lithium toxicity. Digoxin and quinidine toxicity is increased, especially with thiazides. So in toto, what are the indications? To just have it in front of your eyes, closing your eyes, you can just memorize and remember. In case of generalized edema, in acute cases, acute LVF, CF, renal disease, we commonly use high dose of furosemide. In cases of edema and ascites, especially cirrhosis with portal hypertension, spironolactone is the only drug of choice because of primary aldosteronism. Furosemide and thiazide as solo agents will never work. Because of hyperkalemia, we have to add furosemide to combat that effect. Otherwise, you have to start only with spironolactone. In case of non-edematous conditions, used in hypertension, thiazides, diabetic insipidus, paradoxical action of thiazides, hypertensive emergencies, furosemide, glaucoma, acetazolamide, as well as mannitol, high altitude sickness, carbonic anhydrase inhibitors, that is acetazolamide, cerebral edema, it is mannitol. We can use glycerol and urea, but the route of administration is different. Here it is an emergency, so IV, and also glaucoma, that is in acute congestive glaucoma, we use mannitol, which can be given. The only route of administration for mannitol is IV drip. It's only IV drip. We can give orally. It can cause osmotic diarrhea, but it is not used to such an effect because the actions, what we see with diuresis, is not there to that extent, on the GIT. Now, we will come to another 20 minutes. I'll just give you some case scenarios and later on some important points of diuretics where you have to remember throughout your life as long as you are prescribing diuretics. Okay, now the first one, an elderly patient with history of heart disease has difficulty in breathing and is diagnosed with acute pulmonary edema. Which treatment is indicated? Kishan sir? Hello? Hello, Kishan sir?
Yes, madam. I'm his sister.
Are there any patients, are there any students who have logged in so that they can answer?
Yes, ma'am. There are 15 participants here.
If they can, I think they can put it in this chat box so that I can see the answers.
Okay, sure.
If it is possible.
Yeah, sure, ma'am. Participants, please write down your answers in the chat box so that madam can see the answers.
An elderly patient with a history of heart disease had difficulty in breathing, dyspnea, and acute pulmonary edema. Which treatment is indicated and why?
Furosemide, ma'am, it causes vasodilation.
Louder, please. All your voices are very low. I don't know where is the problem.
Because when we give IV, it vasodilation, the pulmonary blood to the systemic.
Hello. Hello.
Madam, he is saying answer C.
Shall I tell the answers or people are there?
Option C, he is saying.
Options are there, no? Acetazolamide.
Yeah, option C.
All red things are answers only. Choices.
Option C, madam.
Options are acetazolamide, chlorthalidone, furosemide, and spironolactone.
Furosemide, ma'am.
Why?
Because it causes vasodilation and shifting of the blood from the pulmonary circulation.
Yeah, that is the reason. And the route of administration is IV. Acetazolamide is given IV, but it does not cause that efficient diuresis what is caused by furosemide, and there is a limit for the diuresis. So no acetazolamide. Chlorthalidone is only oral, and on a long term or even in acute, it does not cause diuresis to that extent as furosemide. Spironolactone is always an add-on drug. So, you more than finding out the real answers, why the other three are wrong, you should be able to know. Then you can be very confident and we can understand that you people have some stuff. Okay, the not just choosing the answers is the problem. You should also know why these things are wrong, and so why these are also given to find out where the mistake is. That is the reason why we want it. Okay, the next one. A group of college students is planning for a mountain climbing trip to Andes, which prevents altitude sickness. Thiazides, anticholinergics, carbonic anhydrase inhibitors, loop diuretics.
Acetazolamide, ma'am.
Sir, your voice is so low, sir. I don't know why. Hello. Hello. Can you hear me now? Hello. The answer is acetazolamide. Why? Because in case of altitude mountain sickness, the oxygen levels are low, hyperventilation takes place. So this will combat with oxygen supply and hence acetazolamide is the drug of choice. Next, an alcoholic male has developed hepatic cirrhosis and to control ascites and edema. Which drug is prescribed?
Spironolactone.
Why? How does it act?
Uh,
How does it act?
aldosterone effect, ma'am.
Aldosterone antagonist at the collecting duct level. At the collecting duct, you have numerous compounds. You have got numerous entities physiologically. One is aldosterone, one is directly acting sodium channels, third PTH, then aquaporin channels. Okay, all and also calcium. These are the 5 important things what we have in the collecting duct, and aldosterone is the main mechanisms what we see here. And so you have to know that we have to block this aldosterone entity, and hence in hepatic cirrhosis as well as hepatic edema, we see that aldosterone is increased. It has got an escape and it increases, and hence spironolactone is the drug of choice. Next, a 55-year-old male with kidney stones needs a medication to decrease urinary calcium excretion. Which diuretic is the best? Hello? Hello? Are you hearing? Hello?
Hydrochlorothiazide, ma'am. Not audible, ma'am.
Hello? Am I audible?
Yes, ma'am. Yes, ma'am.
Audible. Okay. 1 minute. I have made some mixtures here. That's why. Okay. If you, next is so spironolactone. It is aldosteronism, and in case of cirrhosis of liver and ascites, there is aldosteronism, and hence spironolactone is used. In this case, it is hypercalciuria. We have to see that it is excreted, and hydrochlorothiazide is the drug of choice. Torsemide is a congener of furosemide, which is long acting and more potent and can be given once a day. So here it is not useful. We use it in mild doses in case of CCF. And triamterene is again an potassium sparing diuretic, but we use it mainly in cystic fibrosis rather than in the real cirrhosis or other things because of its difference in action compared to spironolactone, though both are potassium sparing diuretics. The next one, a 75-year-old male, hypertension, glaucoma, treated with so many compounds. In the clinic, she complains of acute joint pain, redness of great toe. What is the diagnosis and what medications has caused this?
Hyperuricemia causing gout, ma'am. It's
Yeah.
caused by
Caused by chlorthalidone. Okay. So this metabolic disturbances by furosemide and thiazides are mainly hyperglycemia, hyperuricemia, and also to a certain level increase in lipid levels. So these are the problems which are met. Whereas with amlodipine, we do not find, which is a calcium channel blocker, acetazolamide carbonic anhydrase inhibitor, and lisinopril is an ACE inhibitor which does not cause, whereas losartan causes hyperuricemia, that is ARB. So please don't confuse, both of them starts with L. Losartan and lisinopril. Lisinopril is an ACE inhibitor, whereas losartan is an ARB. Okay. The next one, drug contraindicated in hyperkalemia patient. Drug contraindicated in hyperkalemia patient. Dorzolamide is topical carbonic anhydrase inhibitor. Chlorthalidone, thiazide-like diuretic long-acting. Ethacrynic acid, a congener of furosemide, which mainly causes gastrointestinal bleeding and hence not used. Eprillinone is a congener of spironolactone, which is mainly used in congestive cardiac failure. Eprillinone has got the advantages that it does not have anti-androgenic effects. So that's why we have started using eprillinone than spironolactone. But all the other effects are the same. So this is the one which causes hyperkalemia. I hope you are understanding and you come to know how to analyze it. Okay. Next, 59-year-old male ICU metabolic alkalosis. Which therapy will treat these conditions? The patient is suffering from metabolic alkalosis. You have to bring it to normal or to little bit of acidosis. Amiloride, potassium sparing. HCTZ, thiazide-like diuretic. Mannitol, osmotic diuretic. Acetazolamide, carbonic anhydrase inhibitor, which acts as proximal convoluted tubule, where it will make up for bicarbonate and excretion of bicarbonate. So when the patient is suffering from metabolic alkalosis, use this. All bicarbonates are excreted and hence the condition will come under control. A male patient with resistant, how do you say resistant hypertension? When the patient is taking more than 3 drugs, one of them is a diuretic. He is on a new medication. He has enlarged tender breasts. Which medication is most likely he is taking? Furosemide, loop diuretic, mannitol, osmotic, spironolactone, potassium sparing, triamterene, potassium sparing. This is aldosterone antagonist, whereas this acts directly on the channels. So here it is, enlarged tender breast, aldosterone antagonist. The side effects are anti-androgenic effects and hence gynecomastia is seen. Next, CHF, reduced ejection fraction, heart failure, HFrEF. Okay, this patient has researched. Nowadays we know no Google patients. Okay, they want a Google doctor and he is found that he is taking 2 diuretics and he is worried and he thought it was by mistake that it was given. So what is the response? Bumetanide is a loop diuretic, spironolactone is a potassium sparing diuretic. So you think about the combination, both in actions, uses, adverse effects as well as contraindications and drug interactions. You think. By that time, I'll give you all the 4 options. Spironolactone causes hyponatremia. Spironolactone decreases heart structure changes and decreases risk of death. Bumetanide decreases potassium loss from spironolactone therapy. Or last is duplication error, and one of the drug has to be stopped. Anybody? Explanation from A to D. Are you hearing? Hello? Hello? Hello?
Yes, madam, you are audible.
Yeah. Anybody to explain? Please learn this habit, no? So whatever we are telling, you will try to remember. See, you cannot have for everything notes. Your brain should be notes. 600 pages should come to 60 pages in your brain. That's what I tell everybody. Only then we will have some stuff. With that stuff, we are confident. And with that confidence, you can bombard anybody in any lecture or in any podium. See here, spironolactone causes it does not cause hyponatremia. It causes only hyperkalemia. Okay. Spironolactone, apart from its add-on diuretic effect and causing hyperkalemia, it also has anti-fibrotic activity on the heart. So it decreases the heart structure changes and decreases risk of death. So this is a mineralocorticoid receptor antagonist, which is one of the anti-mortality drugs in CHF. The common question is name 3 anti-mortality drugs in CHF. The first one is AC inhibitors or ARBs. Second one, beta blockers. Third, MRA, mineralocorticoid receptor antagonist. Nowadays, fourth one is newly added SGLT2 inhibitors. Okay, please by heart, and even in the worst of the dreams, you should be able to tell this as long as you put the prefix DR at the back of your name. Okay, so spironolactone mainly has anti-fibrosis activity, so which in turn will reflect the remodeling, which in turn will decrease apoptosis, so that the changes in the heart is decreased, left ventricular hypertrophy is decreased, pumping becomes almost near normal. We cannot do what God has given. We can only make it near normal. And so we can increase the survival rate with good quality of life. That should be added. So simply increasing survival is waste. Better to die. But you should increase the quality of life. So that is done by spironolactone. Definitely, because of anti-androgenic effects, what we are doing, we are switching on to eprillinone. Bumetanide decreases potassium loss from sweat. No, it is not. It is antagonist. Bumetanide causes hypokalemia. Spironolactone causes hyperkalemia. So both are antagonized. And duplication error? No, not at all. And one has to be stopped? Never. Because in reduced ejection fraction, we want all 3 mortality drugs, especially MRAs, so that because of its activity on the heart. These are the reasons what you should really have it in your mind. Last, diuretic in resistant hypertension, which when already treated with 3 BP medication, including a thiazide diuretic. So they must be on ARBs, ACIs, beta blockers, and thiazide. So which one will you add as the 4th diuretic? Fourth drug in resistant hypertension. Mostly we add diuretic to decrease the blood volume. Indapamide, furosemide, mannitol, spironolactone. All are diuretics only. But which one will we add? We will add indapamide. They're already on the spironolactone, sir. Third one, most often they'll be on spironolactone. They mostly will add indapamide. Okay, indapamide, because this is like a thiazide diuretic, a very long-acting drug, and we can give a mild dose, and it is very potent at that small dose, does not cause metabolic disturbances. So these are the advantages. That's the reason why we add this. So now I'll come just few more slides, very few more slides, where important notes are there. Drugs which acts on thick ascending loop of Henle, that is furosemide, is highly efficacious because of more sodium is reabsorbed and the capacity is maximum in ascending loop of Henle, and hence they are called high efficacy diuretics. And they're so efficacious that they produce diuretics even when the GR is only 10 ml per minute. Next, in case of thiazides, each one should be added according to the duration of action. Chlorothiazide or hydrochlorothiazide 5 to 12 hours, or the other one which we never use it, the middle one, or indapamide for 30 hours, or chlorthalidone 47 hours. The duration of action of thiazides is almost the same as I told you in the previous slide. Now, all diuretics, as I told you in the beginning, acts on luminal side, whereas aldosterone antagonists act on interstitial side. Maximum potassium elimination is by carbonic anhydrase inhibitors in an equinatriuretic dose. Both are equal. Bumetanide is most potent, but commonly we use furosemide. The common adverse effects are all electrolyte imbalances, both with loop and thiazide diuretics. And it is important for mineralocorticoid receptor antagonists. Spironolactone are the only diuretics which need not be secreted in tubular lumen to produce diuretic effect. It is the only diuretic which reduces mortality in congestive cardiac failure. Here it is a drug interaction between NSAIDs and loop diuretics or thiazide or potassium sparing diuretics because of renal prostaglandins. This is the comparison of potassium sparing diuretics which I have already told you. Carbonic anhydrase inhibitors, loop diuretics, all belong to the derivative sulfonamide, so be aware of allergic reactions. All thiazides, all three will increase the amount of sodium in the late distal convolutive tubule and enhance potassium and hydrogen and cause hypokalemia, contrast to spironolactone, and the potassium loss by these diuretics by above mentioned mechanisms, and they are useful if combined with spironolactone or amiloride, and this is the rationale of combining and also of sequential blockade. So regarding osmotic diuretics, they are freely filtered, not reabsorbed, increases both osmotic pressure as well as osmolality. When this is very important, when prescribing diuretics in any renal disease, the GFR is below 20 ml, except loop diuretics and metazolone and indapamide. The other diuretics are never useful at all. Acidosis is caused by CAIs, and potassium sparing diuretics causes hyperkalemia. So considering these points, these problems, the best drug of choice in renal disease especially is furosemide. What is the difference between diuretic resistance and tolerance? This is very important, so you should have at the back of your mind whenever you prescribe diuretics. Diuretic resistance is refractory to a particular diuretic, so you should keep on increasing the dose. So how will you overcome it? Increase the dose, allow bed rest, administer just before meals, or use in combination with different mechanisms, sequential blockade, or use it with metazolone. In contrast, drug tolerance, diuretic tolerance is use of furosemide leads to decreased GFR. There, you have to use increase, whereas here it is decreased GFR due to altered hemodynamics. So it is still in trial forms adenosine A1 antagonist. So this is a chart where it shows the urinary electrolyte excretion, maximum sodium excreted, what I showed you in the first two slides, and the efficacy of the diuretics, where we use it and how to use it. Now, this is the most important slide, what you should really know by heart, keep it in your mind. So, all diuretics cause electrolyte imbalance. So, monitor electrolytes. Hyponatremia can be dangerous, especially with cardiac diseases. Pumping mechanism is absolutely altered. Sodium are blocked totally. Patient is fully sleepy. So, be aware. In CHF, the dose of diuretic use is adjusted to 1 kg body weight per day, not just whatever comes to your mind from 20 milligrams to 200 milligrams. Alternate day use of diuresis is often the preferred way of administration in patients with diuretics. You keep this in mind and explain. 1 minute, I'll give you after this. The risk of hypokalemia is higher in cirrhosis patients, and hence we want to use spironolactone. In cirrhosis and ascites, diuresis should be avoided as it precipitates hepatic coma and azotemia, where we can use neomycin, or nowadays we are using lactulose to prevent these things. Diuretic resistance and tolerance may develop. Avoiding dehydration may prevent development or tolerance. So they have to take adequate water. They have to not restrict to 500. At least 1000 to 1250 should be the adequate dehydration should be there. If taken for a long term, preferable to use potassium sparing diuretics along with loop and thiazide diuretics. Why is this important? Alternate day use of diuretics is often preferred way of administration in patients with diuretics. Anybody? Lastly, this is utmost important, drugs which cause edema, NSAIDs, painkillers, arterial vasodilators, hydralazine, diazoxide, minoxidil. Okay. Next, prazosin alpha blocker, hydralazine directly acting vasodilator, calcium channel blockers, especially amlodipine, nifedipine, clonidine, alpha 2 agonist, methyl-dopa, alpha 2 agonist, both in hypertension, pioglitazone, anti-diabetic drug which increases edema. Glucocorticoids are known to cause fluid and water retention, hypertension. Steroid contraceptives, which increases body weight in the females when taken as oral contraceptives. Growth hormone, both somatostatin and octreotide. So all these cause edema as side effect. So whenever we are using this in combination, you should be very, very careful. Thank you for your patient hearing. And I want the reason for this, alternate day use of diuretics is often preferred way of administration in patient. What is the advantage we have? Any idea? Sir, anybody wants
to prevent refractory.
Any other thing? The pulmonary capacity and the action on the vessels because of decrease in electrolyte imbalance takes place. And we need not bother to a great extent about electrolyte imbalance, what we used to when we start on diuretic on a daily therapy. And this is more so when the patient is also suffering from respiratory disorders. Okay. So I think I have covered almost all of them. Thank you for your patient hearing.
Thank you.
Okay, sir. Okay, bye. I hope it was useful. Your comments, please.
Very useful, madam. Very useful.
Okay, sir. We'll see next week. Okay.